a deficiency in the number of red blood cells or hemoglobin within the blood. Laboratory data are required to diagnose anemia, with the most common values ordered being hematocrit and hemoglobin. Normal values for non-pregnant women 18 years or older is a hematocrit of 35.7 and a hemoglobin value of 11.3 or greater. A CBC with differential and a reticulocyte count are also commonly used to screen for anemia. These initial screening tests are later indicators of anemia when compared to biochemical tests for iron status, such as serum ferritin concentration, but are more affordable. The CBC will tell us about the red blood cell size, color, and shape. Red blood cell size, or more specifically MCV, which is the average volume of red blood cells, is used to determine anemia classification, which includes microcytic, normocytic, or macrocytic anemias. An MCV less than 80 indicates a microcytic anemia. MCV greater than 100 indicates a macrocytic anemia caused by folate, B12 deficiency, or reactive reticulocytosis. A reticulocyte count is the number of immature red blood cells in circulation, and it can be used to help determine the underlying cause of anemia. Normally, 1 to 2% of red blood cells in circulation are reticulocytes. A reticulocyte count can be low in anemia, for example, due to insufficient iron levels, which are necessary for the production of RBCs. Once iron supplementation begins, the bone marrow will respond and increase reticulocyte production. For this reason, it's also a helpful tool for providers to assess whether their treatment course is effective. RDW is the red blood cell distribution width and is a measurement of uniformity among RBCs in circulation. A high RDW means that red blood cells vary significantly in size. To determine the underlying cause of RBC size, both the MCV and the RDW are compared. If RDW and MCV are elevated, the provider should consider liver disease, hemolytic anemia, B12 deficiency, or folic acid deficiency. If RDW is high and MCV is low or normal, the provider should consider iron deficiency anemia and thalassemia intermedia, and can also be seen in post-hemorrhagic anemia. RDW may be low due to a microcytic or macrocytic anemia. Ferritin. Ferritin is a protein that stores iron in the body, and ordering a serum ferritin concentration is directly proportional to iron stores within the body. Iron not already attached to hemoglobin can be bound to ferritin and then stored in the liver, bone marrow, and the spleen. The body will deplete its stores of ferritin before iron deficiency becomes a problem, and can therefore be a valuable lab assessment for a provider as an early indicator of compromised iron status. Transferrin is the primary protein in blood in which iron binds. Transferrin levels increase when serum iron concentration is low and decreases when serum iron concentration is high. Serum iron concentration is a measure of the total amount of iron in the blood bound to transferrin. This value fluctuates throughout the day and unrelated to anemia, for example, infections or inflammation. Therefore, serum iron should not be evaluated alone, but it can be useful in relation to transferrin levels and serum ferritin. TIBC, total iron binding capacity. It's a measure of the iron binding capacity within the serum.